The current crisis we face in the NHS is that doctors believe they're not being paid enough for their work.
Station 1. Should doctors have to pay for prescriptions in the NHS?
So to answer this first question, we have to look at the very important NHS principle that states that healthcare is free at the point of delivery. And what this means in the UK currently is that prescriptions are £9.65 per item. However, there are a few exemptions to this rule. Patients who are in full-time education up to the age of 18 receive free prescriptions alongside pregnant patients, patients who have diseases like epilepsy, cancer, as well as patients who struggle with income-related problems. So here we can see that a lot of people do benefit from these free prescription charges. However, there is an argument that certain NHS employees, like doctors who contribute quite a lot, will benefit from reduced or essentially free prescription charges. The current crisis we face in the NHS is that doctors believe they're not being paid enough for their work. And one way to tackle this problem is, instead of increasing their pay, we can reduce their costs in another way by, for example, making their prescriptions free. And this is particularly the case for junior doctors who receive a very modest salary, and therefore by reducing their prescription charges, reduce the financial burden on them. And this can potentially help motivate them to continue being junior doctors in the NHS and continue doing a lot of good work. However, the main argument against this notion is to do with the main principle of justice or fairness, where a lot of people argue that doctors, once they become patients, they should be treated like any other patient and should, in that particular case, pay for prescriptions when needed. So to answer this question, I'd say we need a very balanced approach. However, this principle also means that we need to extend the exemption to other NHS staff, such as nurses, physiotherapists, who also contribute a great deal towards patient care. So to answer this question, I think a very balanced approach is needed, where if we are subsidising prescription costs and we're doing it in a way that doesn't exhaust our resources, which are already being stretched, but also extends not just towards junior doctors and doctors, it extends towards the entirety of the NHS staff.
Station 2. What do you think the NHS will be like by the year 2075?
Although it's very difficult for us to predict that far into the future, we can look at the current challenges that are already being tackled right now by the NHS and how that's likely to continue in the future as well. So first of all, I'm going to talk about the current challenges of the NHS surrounding our ageing population, funding, waiting times, and then I'm going to move on to talking about how the NHS is hoping to tackle those problems in the future. So the main problem regarding ageing population is that although thanks to the wonderful advancements in medicine over the past century, our population is actually living for a lot longer, these extra years that they're alive for aren't spent in good health. In fact, they have a lot more comorbidities, which leads to a decrease in QALYs, as well as draining our resources to tackle the healthcare problems that they have. Additionally, with the NHS budget already being pushed to its max in primary, secondary and tertiary healthcare centres, different funding models and different more sustainable models will need to be implemented in the future as well. Furthermore, we also have problems surrounding our workforce shortages, where it's adding to already existing pressures. So we're seeing increases in our nursing staff, our doctors and other healthcare professionals. It adds to a more significant problem, which is longer waiting times, which number one are very frustrating for our patients, but also mean that they are less likely to access healthcare due to how long they have to spend in A&E. But it also means that the current conditions that they already have, they're less likely to seek help for them, which may lead to their conditions worsening and leading to even more complications and emergencies further down the line. So to tackle this problem, the NHS has in place the NHS long-term plan, which one involves the implementation of technology and innovation to tackle these big problems. So this plan might mean we have more technological advancements, where we're seeing more AI, more digital medicine, robotics, telemedicine to alter our healthcare. We may see a greater implementation of personalised medicine, where we have more targeted therapies for particular genetic problems. And additionally, we may also see a greater focus on preventative medicine, which would decrease the pressure on secondary and tertiary centres where the majority of funding goes to. And finally, in the future, we might also see a hybrid model between private and public healthcare. So we have access to funding and resources so we could come up with these innovative ideas and solutions.
Station 3. Apprenticeship models in medical training may offer a practical approach to learning. What measures will ensure that doctors receive comprehensive and standardised training?
So, apprenticeship models are essentially a way for students who want to be doctors for them to study and work as healthcare professionals alongside their entire training program. And what this means is that the learning that they receive is very hands on, and therefore they learn a lot more, they absorb a lot more things. However, that being said, we need to have a lot of measures in place to make sure that the training that they do receive is standardized and comprehensive so that it matches the training that their peers receive, but also the training that their peers who undergo the normal 5 to 6 medical training pathway receive as well. So, certain ways that we can make sure that this training is standardized is by making sure that they have regular assessments, there's the correct oversight, as well as having curriculum standardization. So, what we mean by curriculum standardization is that the core knowledge and the competencies that these trainees have is uniform across their whole year group, for example. And in order for this to be the case, they need to have regular assessments throughout their training, assessments that test their skills and their knowledge in both summative and formative ways as well. Additionally, we also need to make sure that the kind of rotations that they're receiving throughout their training in different specialities is as diverse as possible, again, so that it's similar to the training that their peers receive who do the normal 5 to 6 medical pathway too. That being said, another very important way to make sure that things are standardized is that we have a large body monitoring the progress of these trainees. And finally, we need to make sure that there is a good level of oversight throughout this training pathway in this model. So, whether that be through consultants, experienced consultants who can oversee the training via mentoring programs, or via big organisations like the General Medical Council and similar bodies to regulate and oversee the training pathway as a whole.
Station 4. Why do you think NHS doctors leave to pursue careers in the private sector?
So, this is a very complex career decision that many more physicians over the years have been undertaking. And there are several factors that can lead to clinicians being pushed towards the private sector. And these include things like financial incentives, quality of life, burnout, career progression, all of which I will talk about to answer this question. So, private practice often involves higher financial incentives. The jobs and the salaries in the private sector often pay a lot better, and there are more rewards that come with that. Additionally, there's better work life balance. You have more control over your hours, where you work, how much you work, all of which can be very enticing towards clinicians as well. And furthermore, the private sector often also involves a better career progression trajectory where there's more opportunities to specialise and gain more experience in roles that you want to go into in the future. Additionally, there's overall better job satisfaction. If we consider the shorter working hours, the better pay, the better work-life balance, all of which is something that doctors struggle with within the NHS. The main thing that we've seen in the news, especially over the past few years about the NHS, is that doctors and healthcare staff struggle significantly with burnout, where they're working overtime, often understaffed, and essentially in conditions that are very high pressure. All of these things together can push a clinician towards pursuing a career in the private sector. However, that being said, this decision again is very complex, and it's usually a multitude of these things all together that lead to a clinician making this decision.
Station 5. Is the NHS better prepared to respond to a public health emergency now compared to before the COVID-19 pandemic?
The recent COVID-19 pandemic created huge ripples across all healthcare systems across the globe. This led to a lot of lessons being learnt around things like healthcare infrastructure, supply chains, workforce readiness, and the role of digital health as well. However, there are still some challenges that remain, and all of these I will discuss in order to answer this question. The pandemic did indeed highlight a lot of weaknesses, but it also helped us improve our response mechanisms, some of which are still being implemented to this day. In terms of infrastructure improvement, we saw an enhanced capacity for testing and tracing the COVID-19 disease, as well as enforcing and planning large-scale vaccination programs across the UK. And due to initial problems that we had with the lack of equipment, now we have a greater focus on PPE, medical equipment, and emergency stockpiles in case this were to happen again. Social distancing also meant that we saw a lot of our primary healthcare GP consultations be online instead of face to face, and this worked significantly well, which has led to a lot of consultations still being kept over the phone or online. And finally, the pandemic also meant that we saw great improvements in our collaboration between the NHS, other public sectors, and the government, meaning that hopefully, if there were to be another emergency, public health emergency, the response would be a lot quicker. However, there are still some challenges that remain that we're still tackling, and ones that could actually be detrimental if another pandemic were to happen. And these revolve around funding, as well as the workforce shortages that we still have. So say if another pandemic were to happen, with the current budget of the NHS already being stretched, we might not have enough money to implement large-scale vaccination programs or to ensure that we have enough PPE. And with the workforce shortages, we might not have enough staff to cover the increased pressure that we saw in the pandemic as well. However, that being said, we have learned a great deal. We have seen great improvements in our infrastructure, and if this were to happen again, hopefully we'd be a lot better equipped and more knowledgeable.
Station 6. You are the manager of a local NHS trust and you have been allocated an increase to your annual budget. Would you prioritise directing the resources towards clinical care or research endeavours?
So to answer this question, I will look at both the clinical care as well as the research priority behind allocating my resources in my local NHS trust. If I prioritise the majority of my budget towards towards the more clinical immediate funding, it means that it has a direct impact on my patient outcomes, where I'm able to address problems in waiting times, staff shortages, and lack of equipment. This enhances patient satisfaction, but also increases trust in the healthcare system as a whole as well. And it also supports a very important core principle within the NHS, which is that healthcare is universal for all. However, it's also very important to consider how important allocating resources towards research can also be important. So allocating funding in this area has very long-term benefits, where innovation and improvements in treatment prevention, for example, can have a lot of good outcomes in patient care in the future. Targeting my funding towards more research-related endeavours also attracts talent and partnerships and makes the NHS a leader in global innovation and disease prevention, for example. So all in all, both of them, allocating resources in both aspects, have great outcomes. So how I'd approach this decision making is I'd allocate the majority of my resources towards initial clinical management. The majority of my initial funding would be going towards reducing our waiting times, increasing the number of staff that we have on the wards, as well as increasing the equipment that, for example, the staff and the patients need as well. However, I would also allocate a good portion of the funding towards research as well, where potential treatments or innovations can target clinical pressures that we're seeing.
Station 7. Should the NHS provide free eye tests for all patients?
So currently in the NHS, eye tests are free for patients 18 and below and 18 and above, but only if they're in full-time education such as college and university. Eye tests are also free for older patients 60 and above. However, if you do fall between those ranges, you do have to pay a fee when getting an eye test. And to answer this question, there are key concepts that we need to consider, particularly accessibility and prevention versus resource allocation. The main reasons for this notion surround disease prevention, as well as the key ethical concept of justice, and the main reasons against this notion are the financial implications that come with such a task, as well as, again, resource allocation. And I will be discussing both sides in order to come up with a conclusion. If we were to make eye tests free for the entirety of the population, it promotes early detection of important diseases like glaucoma, cataracts, and diabetic retinopathy, which is more prevalent in the older population. It acts as a preventative measure, reducing further costs that would have been spent if these diseases were to progress and get a lot worse. Now, if we consider the very important ethical principle of justice, which states that healthcare needs to be accessible to all, making eye tests free for everybody comes under that principle, meaning that everyone, regardless of whatever financial background they come from, has equal opportunity to access good healthcare for their eyes. Now onto the main arguments against this notion. These surround the financial implications and, like I said, resource, as well as the resource allocations behind this as well. If we were to make eye tests free for everybody, it would add on to the already increasing pressure on the current resources that the NHS needs to allocate. And this increase in demand would also increase the waiting times for patients as well. Although the principle of justice states that healthcare needs to be equitable for everybody, in the case of eye care, it actually might be counterintuitive, since the focus might shift away from more immediate eye pathologies towards ones that are less urgent. So in my work experience at the eye clinic, we saw a lot of patients that come in for things like abnormally sized optic nerves, which essentially is more of a genetic abnormality in anatomy as opposed to it being a medical problem. And this was the case for a lot of patients in the clinic, and it led to a lot of time being wasted by the consultant and all the healthcare staff involved. And this problem might be exacerbated if we were to make eye tests free for everybody, because there would be an increase in demand. So how I'd approach this situation on whether to make eye tests free for everybody, I tried to find some sort of middle ground where we're able to give free eye tests for more high-risk groups. So we might consider decreasing the age of free eye tests to 50 as opposed to 60, or making eye tests free for people with particular conditions such as diabetes, or older adults, or even patients who have family histories of eye pathologies.
Station 8. What are the unique healthcare needs and challenges faced by the LGBTQ plus community, and how can they be addressed?
Over the decades, even centuries, this particular group of people have been marginalised, stigmatised, alienated, but also unfortunately punished as well for being who they are, with same-sex marriage in the UK only becoming legal in 2013. And to answer this particular question, I'm going to cover the unique healthcare needs of this group of people, the challenges they face, and how we can appropriately address these issues in a manner that betters their health overall. The main healthcare needs that encompasses the LGBTQ plus community is to do with their mental health, the risk of getting certain sexually transmitted diseases, barriers to accessing healthcare due to fears of being stigmatized against. And these are all things that I saw in my work experience at the gum clinic earlier on. So the LGBTQ plus community, I saw that they had a higher rate of things such as anxiety, depression, often linked to the discrimination and the stigma they've experienced across their entire lives. And also I saw that there was an increased risk of certain infections such as HIV, particularly in subgroups of the LGBTQ plus community, for example, in men who have sex with men. And I also saw that they often face barriers when accessing clinical medical services, to address these challenges, because, they feared that they'd be discriminated against, they feared that they wouldn't be understood, but also they had previous negative experiences, which meant that they didn't want to come into clinic at all. So the main challenges that I learned from my work experience was that there was lack of adequate training for healthcare professionals surrounding the particular needs of this group of patients, as well as the invisibility in medical research when it came to tackling their unique problems that led to gaps in research and knowledge, as well as also the very important challenge of societal discrimination, which affects their health as well as their access to healthcare as well. And there are lots of ways in which we can address their needs, and it encompasses things like education, policy making, as well as collecting the right kind of data. So in terms of education, we can benefit this particular community by implementing more thorough training to do with their specific needs in medical school, for example, or even in hospitals providing seminars for all healthcare staff to attend and learn more. Additionally, we can also implement policies that target the non-discriminatory care and inclusive services that we want to give these patients as well. And finally, we can improve our data collection techniques to make it so that the healthcare services that we provide are more targeted towards the LGBTQ+ community.
Station 9. Should doctors specialise sooner in their careers?
So to answer this question, it's important to initially look at the current training pathway in the UK. So after finishing medical school, most doctors do a foundation year 1 and year 2 where they cover a broad range of specialties. And then after that, they decide which one they want to specialise in, and then they follow the training pathway for several years until they become consultants. So to answer this question, the key concepts at play here is to do with the breadth of generalist experience and the depth of specialty expertise. So the main arguments for early specialisation are to do with having more knowledge earlier on, potentially having more training posts available, and reducing burnout. And the main arguments against this particular notion are to do with increased knowledge gaps, loss of skills, and also not having enough time to make a decision like this. Allowing doctors to specialise in their particular chosen specialty earlier on essentially means that they'll have an increased knowledge in that field a lot sooner, and they wouldn't have to spend any more years or time out of their life to learn more, essentially. And this might also mean that we might see the shift focus more towards increasing the number of specialty posts earlier on, and this can in turn decrease the number of waiting times and pressures we may see in these particular specialties, with patients seeing earlier on, since there are more doctors who are training in the particular pathway. And additionally, it can also prevent the very important issue that we're seeing, which is rising in junior doctors, which is to do with burnout. Being able to specialise a lot earlier on means that they'll be spending less time in their junior years, which are known to be very intense, and therefore would be fitter and healthier enough to continue with the rest of their careers. However, there are a lot of arguments against specialising early and losing the more generalist experience you have when you are a junior doctor. So if you do specialise a lot earlier on, say right after medical school, then you reduce the exposure that you have to a variety of medical fields, and this might in turn lead to a lot of knowledge gaps in other specialties, which actually might be relevant in your particular specialty as well. Additionally, by specialising a lot earlier on, doctors may actually lose opportunities that they experience in general medicine that contribute to a more holistic care for their patients. And this might be things, after having spoken to a lot of doctors, being up to date with the current medical procedures needed for all patients, like IV infusions or bloodletting, which particular specialties aren't very used to once they complete their training pathway. And finally, medical students and junior doctors may actually not have enough experience or time to come up with such a life-changing decision as well if they come straight out of medical school and go immediately into training pathway. So being exposed to more general medicine first can help with this decision making by allowing them to, for example, take more foundation years to learn more about the different specialties, and then go into one that they feels like aligns more with their values and their skills. So to answer this question, how I'd approach the situation is I'd allow some doctors who are very certain on the specialties that they want to go into to have these early training posts available for them. However, I'd also allow for doctors, medical students who are unaware of what they want to do, and let them have the opportunity to take as many foundation years as possible so that they can learn as much as they can about all the different specialties and then make a decision a bit later on.
Station 10. Compare the distinct roles and scope of practice for physiotherapists and nurses in the healthcare system.
Both nurses and physiotherapists have a very important role in the healthcare system. They both provide very important care for patients throughout the entirety of their patient journey. And to answer this particular question, I'm going to compare and contrast the roles of these two professions, need for specialization, as well as the contact they have with patients day to day. So in terms of the role of physiotherapists, for example, after having been at an orthopedics hospital, I saw that they were very much involved in rehabilitation of patients, whether that be due to musculoskeletal problems, respiratory problems, and just general mobility issues as well. And to provide help, they do very targeted manual therapy, very targeted exercises in order to improve their lives. Nurses, on the other hand, although they do improve patient outcomes, they do it in a slightly different way. They are responsible for patient care in the sense that they administer drugs, they monitor the patient's vitals, they provide the patient and their family education regarding their disease, and they also, very importantly, provide emotional support when the patients are in hospital as well. In terms of the ability for these particular roles to specialise, physiotherapists can indeed specialise in particular areas of the human body, for example, in the neurological aspect, in the musculoskeletal aspect, again, in respiratory care to tackle diseases like COPD, PEs, orthopedics related problems, problems posed due to diseases like Parkinson's, for example. So they can specialise in all sorts of areas. Nurses, very similarly, can also specialise in various fields, including critical care, paediatrics, cardiology, and all the way to mental health and public health as well. So again, both of these roles have great scope to specialise. And finally, in terms of the day-to-day patient contact that physiotherapists and nurses have, physiotherapists have very intensive one-on-one care that not only lasts a couple of hours, it can last throughout the patient's whole life, for example, if they have very chronic conditions and need support long-term. Nurses, they tend to provide, in hospital settings, they tend to provide support in the bedside. So they provide day-to-day patient, so they provide care for the patient's day-to-day needs. They coordinate between other multidisciplinary teams, whether that be with physiotherapists, with doctors, with social care workers. Again, both of them have similar but different ways that they support patients. Both roles, again, are very important in the healthcare system. And physiotherapists, particularly, they work on physical rehabilitation, whereas nurses, they're able to facilitate that by improving patient needs, but also collaborating with physiotherapists at the hospital.